We are very fortunate tonight to have Associate Professor Manish Patel back with us. He's a faithful supporter of this support group. I don't know how many times you've come, Manish, but it's quite a few.
A few, yes.
And Manish doesn't really need an introduction. It says a lot there. The one hospital that, well, actually there's a few hospitals that he works out of: the Sydney Adventist Hospital, the Westmead Hospitals, private and the ordinary, well, the public hospital. The Norwest Hospital, I thought you...
I've stopped there now.
Stopped there?
Yeah.
But the other one is Macquarie.
That's right.
Where Manish performs the robot-assisted radical prostatectomy. So we are very privileged to have Manish here tonight, as we always are. His presentation is always very enlightening, and one of the best parts, apart from a very good presentation from a distinguished urologist, is the question and answer session afterwards. So without further ado, could you please help me welcome Associate Professor Manish Patel.
Thank you, David and Pam, and thank you for the kind invitation. I love coming back here, and I have to say this is always the largest support group that I talk to, and certainly the most enthusiastic, and definitely have the most questions. And I guess also welcome to the other support groups around the country now that this is being DVD'd across everywhere.
115 support groups.
115, fantastic. Okay, so Pam asked me to talk about new developments in advanced disease. Now, I guess first of all, to start off with, we've got to define what exactly we're talking about. And what we're talking about is cancer that has already spread beyond the prostate. Now, that could mean either locally into the surrounding tissue around the prostate, it could mean to the lymph nodes, or it could mean to the bone. Okay. In some cases, when someone's had a prostatectomy or had radiotherapy and the PSA is now rising, we also consider that as advanced disease, even if we can't see any evidence of cancer in the bones or in the lymph nodes. We suspect that it possibly is there. We just haven't been able to find it on a bone scan or a CT scan. So now, what are the new treatments that we have for advanced cancer? Well, some of you may recognize this. This is a what we call a 3D conformal radiotherapy suite. And the whole idea of radiotherapy is to focus in X-rays in on the prostate, and a number of you may have had this sort of treatment. Now, we know that not all prostates are the same. You can have a low-grade cancer, like a Gleason 6 prostate cancer, and the treatment or the dose of radiotherapy you need for that is actually less than what you need for someone who has a Gleason 7, and someone who has a Gleason 8 or a Gleason 10 prostate cancer, that's a more aggressive cancer. We know that you need a much higher dose of radiation. And if you look at these curves, this is basically the cure rate for someone with a really nasty cancer with different radiation doses. So this is only 64 gray, and if you go to a 70 gray, it increases dramatically, and if you go to a 75 or to an 80 gray, it increases dramatically. But what's the problem with giving too much radiation? Well, you can damage the surrounding structures, which are usually the rectum and the bladder. And you can see here, this is our standard 3D conformal radiotherapy, and the beams of radiation go through the whole body and sort of focus in on the prostate, but the rectum can get a fair bit of the dose as well. And one of the new developments, which at least half of the radiotherapy centres around Sydney have now, is something called IMRT, which is intensity modulated radiotherapy. And what IMRT does is that instead of having square-shaped X-ray beams focusing on the prostate, they actually shape the beam continuously as it's spinning around the patient, and can focus the beam in much, much closer to the prostate, and hence decreasing the damage you do to the rectum, to the bladder. And what that allows you to do is get a higher dose to the prostate without doing too much damage. So that's certainly been an improvement. What else can we do to improve radiotherapy? Well, there's something here called HDR brachytherapy. And what you're looking at here are the hollow needles that are going through into the prostate, just below the bladder. And through these hollow needles, we can give a very, very high dose of radiation. It's called iridium. And that iridium is given twice while the needles are in, just for a few minutes. And that's another way of getting a very, very high dose of radiation into the prostate gland without coming externally and damaging the rectum and the bladder in the process. So this is called HDR brachytherapy. What other improvements have we got to patients with locally advanced prostate cancer and radiotherapy? Well, this is quite an old study, so I won't say it's a new development, but it's a study by a guy called Bowler in Europe. And what he showed is that if you have patients with locally advanced prostate cancer, that is a cancer that's very high in volume, possibly gone through the capsule of the prostate into the surrounding lymph nodes, and you give radiation only, then the treatment effect at 7 years really isn't that good. This is the percentage of patients that don't have cancer. But if you give hormone therapy along with the radiotherapy, you can see that you get a dramatic improvement in the treatment effect. And at 7 years, you get at least a 30 or 40% improvement in cancer-free patients. And so this has now become a standard of care for us. We generally always give radiation and hormone therapy together when you have locally advanced or really nasty prostate cancer. So let's look at another scenario, a man with a rising PSA. Okay, so suppose a man's had a radical prostatectomy. He's surgically had his prostate removed, and the PSA starts rising. And generally we say the PSA is rising if the PSA gets greater than 0.2. Okay, on average it takes about 2.3 years to actually see a rise if a patient's going to have a rise. Now that's an average. Some men can have it immediately after prostatectomy, and some men can even have it after 5 years. But 2.3 years is really the average. Now once you have a rising PSA, a lot of men think, oh my God, I've got cancer back again, this is terrible. And in reality, it's actually not that bad. I mean, if you're going to get recurrence of any type of cancer, prostate cancer would probably be the one, because if you look at here, the median, or rather the average time it takes for a PSA to start rising and for the cancer to actually manifest in the bone by a positive bone scan is about 8 years. So that's a very, very long time between when that starts. Now again, that's an average, so some men will be shorter and some men will be longer, but it does take a very, very long time. And again, another very long time before those bone metastases cause any sort of real harm. Okay? So the important message to take away here is that just if you have a rising PSA, it's actually not that bad a scenario. Now, if your PSA rises after you've had a prostatectomy, where is this PSA coming from? Well, it's coming from microscopic cancer that's still somewhere in the body. Unfortunately, when the PSA is very low, we don't have any way of knowing exactly where this cancer is, because it's microscopic. No bone scan, CT scan, or MRI is actually going to pick it up. So there's a number of ways that we look at trying to figure out where this cancer is. And what the ways are is we look at the original cancer that we treated with prostatectomy. If it was a really big, nasty cancer, then the likelihood is that the cancer is going to be more distant, that is in the lymph nodes or in the bone, than actually locally, that means in the pelvis where the prostate was taken out. If the PSA rises very quickly after surgery, it's also more likely to be more distant. And if the PSA is rising very rapidly, it's more likely to be distant. And the reason why that distinction is important is because we have to decide on whether radiotherapy to the pelvis would be of any benefit in trying to get rid of that PSA rise. If we think that the cancer is most likely still sitting there in the pelvis, then we would probably recommend some radiotherapy to the pelvis. It doesn't always work, but in the vast majority of patients who we do recommend radiotherapy for, it does work. That is, 7 to 80% of men it does work when we recommend it. But if we think it's more likely to be somewhere else, that is in the bone or in the lymph nodes, then radiotherapy is not going to help. And the treatment there would then be hormone therapy. And we've actually recently got lots of new tools called nomograms that can help us decide, or rather help predict where this cancer is going to be. Now, what happens if you have a rising PSA after you've had radiotherapy? Generally, in most patients, if a PSA rises after radiotherapy, it usually means the cancer is either microscopically in the bone or in the lymph nodes, and hence having any further treatment to the prostate is not going to be useful. But in some men, it is useful. And in those men, it's the PSA that's rising very, very slowly, and those men that had not so nasty a cancer in the first place. And if we biopsy those men and we find that there is cancer still left behind in the prostate, then it is sometimes worthwhile doing what we call a salvage prostatectomy. Now, salvage prostatectomy is taking your prostate out after you've had radiotherapy. It's not very frequently done because it's a very difficult operation. You need a lot of experience, and despite having a lot of experience, you can still get a lot of side effects, and incontinence is one of the major ones. But where I trained in New York, we had the largest experience of prostatectomies after radiation. And what we found is that if the patient's original cancer had a PSA of less than 10, that is before radiation, their Gleason score was less than 8, and we do find positive prostate biopsies after the radiation, then they're eligible. And intraoperatively, because radiation turns everything into scar tissue, there is a higher incidence of injury to surrounding organs, but I have to say, in my experience, that hasn't actually happened yet, so that's very good. Postoperatively, the incontinence rate is higher. It's 33% compared to, say, if you didn't have radiation, the incontinence rate is down as low as 2 to 3%. But with that incontinence, we can treat it with an artificial sphincter. So when I talk to patients about having this sort of an operation, I tell them it's a two-stage operation. We take the prostate out, and then there's going to be a very high chance we're going to need to put in an artificial sphincter as well. It's just part and parcel of a salvage prostatectomy. Unfortunately, when you do a salvage prostatectomy, because of all the scarring, etc., impotence is very common, and I usually counsel my men that it's just part and parcel of the operation as well. But if we catch the cancer early, that is the PSA is rising after radiation, and we catch it soon rather than waiting too long, the results are actually very, very good from a cancer point of view. Now, let's talk about a different scenario. Patients, men who have cancer in the bone. Okay, how do we treat men with cancer in the bone? That's another form of advanced prostate cancer. Well, we've got to take a lot of things into account. The man's normal life expectancy, how they're currently feeling, what sort of symptoms do they have, what is their current quality of life, and what do they want out of treatment, and what do they want to achieve in life with this disease. We've also got to take into account how aggressive the cancer is. For example, someone may be feeling really well and have all these aims of doing lots and lots of things in their life, but you know, even if they're asymptomatic, if you've got a very, very aggressive cancer, we need to jump on it and treat it just to make sure that that quality of life does not deteriorate very quickly in the future. So how do we treat men with metastatic cancer, which is generally in the bones first, but it can go to other spots after it goes to the bones? Well, we treat what we call androgens. Now, androgens are a form of hormones. There's lots of different types of androgens, and testosterone is the most common androgen in men. Testosterone is produced in the testicles, and then the testosterone travels to the prostate and to the cancer, and the cancer actually has receptors on it for the testosterone, and that helps the cancer grow. If you take away the testosterone, the cancer actually shrinks because it does need testosterone to live. Now, there's a guy called Charles Huggins in 1966 who actually discovered that if you take away the testosterone, prostate cancers shrink, and he actually also did some studies on breast cancer as well, and he got the Nobel Prize for that. And he did a whole heap of experiments where he castrated old dogs, and old dogs actually get prostate cancer. They're the only other animal that we know of that gets prostate cancer. So he castrated them and then found that he could actually treat their prostate cancer by castration, and that's where the whole idea of hormone therapy came in. Now currently there's a couple of different ways of achieving castration, or rather reducing the testosterone. There's surgical, and surgical basically means removing testicles. It used to be the only way probably about 2 or 3 decades ago, but now this is very rarely performed, not only because it's an operation, but it has quite significant psychological effects. And later on I'll talk about new developments that make this surgical method really obsolete. And then there's medical means of castration. And there's actually quite a few drugs out there where you can achieve medical castration. Men here that are on medical castration treatments, you'll almost all be having what we call LHRH agonist, either Zoladex, Lucrin, or Eligard. There's actually a new class of drug that's come out called the LHRH antagonist, and I'll explain what the difference is in a few slides. But there's also some tablets that you could take, and some of you may have taken it already, Androcur and Kosiudex. And these anti-androgens, I'll explain in the next slide exactly how they're different from the LHRH agonist, that's the injections that you take. So let's look at this diagram. This is your brain, and in your brain there's a tiny little center called the hypothalamus. The hypothalamus sends out a hormone called LHRH, and that goes to your pituitary. So the LHRH binds a receptor in the pituitary, and it gets stimulated, and when it gets stimulated, the pituitary gives out 2 hormones, one called ACTH and another one called LH. ACTH goes to the adrenal glands and stimulates the adrenal glands to produce a whole heap of hormones. The LH goes to the testicles and stimulates the testicles to produce testosterone. Now, the LHRH analogues, what they do is that they block the LHRH here binding to the pituitary gland. And when that happens, obviously the LH decreases and the testicles stop producing testosterone. However, when that happens, your adrenal glands can still produce a small amount of hormones or androgens similar to testosterone, and they can still stimulate prostate cancer growth. So how do we stop that tiny amount that's produced here? Well, that's when we use the tablets, the anti-androgens. Now what the anti-androgens do is they block the testosterone receptors, or rather androgen receptors they're called, on the actual prostate gland. And so if there is any androgen circulating from, say, the adrenal glands, it'll stop it working on the cancer at this level. Does that make sense? Yep. Now, the great news is that prostate cancer metastases are very, very, very responsive to hormonal therapy, or we call it hormonal therapy, but in reality we're taking away the hormone, so it's not really hormonal therapy, but rather androgen deprivation therapy. And that's why we don't have any other treatment that takes its place. Any patient that has advanced disease or metastatic disease, we always give hormone therapy first, because no other medication comes anywhere close to the effectiveness of this. And you can see in this man, see these little dark black spots? They're all little bits of cancer in the bone. And you can see it there, a bit down the legs here, a bit in the bone here, all the way up here in the ribs, down the shoulders. And after 9 months of hormone therapy, you'd be lucky to, I think that's probably the only spot that you'd really pick up as being definite cancer. And maybe a tiny bit there and a tiny bit there. So there's a huge difference here, and that's how effective androgen deprivation therapy is. But of course, androgen deprivation therapy or hormone therapy has side effects, and we're only starting to learn just how serious some of these side effects are. Most men on it know that they'll get some degree of hot flushes, similar to what women get when they go through menopause. With time, because of the lack of testosterone, they tend to lose muscle mass and also get quite tired. But an important thing that we've now started sort of realizing in the last 3 to 5 years is something called metabolic syndrome. And your GP may have talked to you about it. Metabolic syndrome is a constellation of signs or factors that occur that increase your risk of developing heart disease. And they are increasing waist measurements, increasing fat, increasing your cholesterol levels, hypertension, and diabetes, they all go together. And unfortunately, the androgen deprivation therapy does increase your risk of metabolic syndrome, and hence it increases your risk of developing a heart attack or a stroke. And so whenever we put someone on this treatment, we always warn the GP that you have to be monitored very, very carefully for all of those factors, and obviously treated if any of those factors arise. Now, another thing that occurs is osteoporosis. And so anyone on this medication should really be having yearly DEXA scans. And DEXA scan is a special scan. It's not a bone scan, but it's a special scan that looks for osteoporosis. And every year, if we find that you're getting more and more osteoporotic, then we need to do stuff to try and reverse that and get the calcium back into your bones. The hormone therapy will affect libido and potency, and there's also lots of work we can do to help you in that area. It can cause anemia if you're on it for a very, very long time. And again, something else we're starting to learn is that it does cause difficulty with moods, mood swings, sometimes depression, and your partners need to be well aware that this can occur and bring it to the attention of the GP or your urologist or whoever's looking after you. The other thing that can occur is something called cognitive impairment. That is difficulty concentrating or thinking at high levels. That is things like arithmetic or memorizing or orienteering yourself, reading maps, stuff like that can be quite difficult. Not everyone gets it, but some people do. Now, there's a new drug on the market. Zoladex, Lucrin, Eligard are all what we call LHRH agonists. That is, when you get the injection, the drug goes to the pituitary gland, and initially it stimulates the receptors on the pituitary, making you have a surge of testosterone, and then it overstimulates the receptors and the testosterone plummets and goes down to almost zero. So you can see here exactly what happens. If you get an injection of, say, Zoladex or Lucrin or Eligard, your testosterone actually goes up over the first few days and then slowly comes down over 14 days to very low levels. Now, if someone's got a lot of cancer and your testosterone temporarily goes up before it goes down, that cancer can actually grow in that short time period. And particularly if you've got very painful cancer metastases in the spine, that can be a problem. So this new drug was developed called Degarelix, or it's basically what we call an LHRH antagonist. So instead of stimulating the receptors initially before it drops the testosterone, it completely blocks it right from the beginning. And you can see when you get the injection, it drops down and stays down very low. So what this means is if you take this drug, you don't need to take what we call flare cover, about 4 weeks or 6 weeks of tablets to cover the testosterone flare that you get here. Does that make sense? Okay. So, who should get androgen deprivation therapy or hormone therapy? Well, there's actually quite a large number of different scenarios that could be getting them. Someone who has obvious cancer in the lymph nodes or in the bone or other organs very definitely need to have hormone therapy. Someone who has what we call locally advanced prostate cancer, that is, the cancer hasn't spread distantly to the lymph nodes or to the bone, but there's a lot of cancer locally in the prostate and it's gone through the capsule of the prostate into the surrounding areas. Hormone therapy or androgen deprivation therapy will actually shrink that cancer down and stop any problems from arising locally. Men that have had treatment, either prostatectomy or radiation, and it hasn't worked and the PSA is rising despite that, but there's no evidence of cancer in the bones or the lymph nodes, could be on hormone therapy. Or as I said earlier, you could have hormone therapy during or afterwards, after radiation. Now, for people that have metastatic disease, how soon should it be started? Well, we have a number of studies that show the earlier it starts, the better, except we just don't really know how early it should be. For example, the studies that I'm talking about are all in men who had obvious cancer in the bones. So if you have cancer in the bones but you have no symptoms, you should start the hormone therapy straight away. But we've got a new category of people, that is patients who have had treatment with prostatectomy or radiation and all they have is a rising PSA. We actually don't know when to start hormone therapy on those patients because there's no studies that have actually looked at it and said, well, it's good if you start it later or it's good if you start it earlier. And so we basically look at how fast the PSA is rising. In someone who has a rising PSA after treatment, if the PSA is rising very quickly, we know that they're going to develop metastases in the bone very quickly as well. And hence we start hormone therapy early in those patients. Someone who has a very slowly rising PSA, it's going to be a long, long time before these men develop cancer in the bones. So we can actually delay the hormone therapy until the PSA gets to a much higher level. Now the tablets, the anti-androgens, which is Cosidex or Androcur, some of you may recognize that tablet. Is there any advantage to adding it to the injections, the Zoladex, Leukerin, and Eligard? And the answer is yes, there's a very small benefit, and it's really, really small. It's only 3%. And the question we've got to ask then, well, is a 3% improvement worth the side effects that you're going to get from the tablets? And really, basically, what we should do is talk to you and say, look, these are the side effects, this is the benefit. What do you think? So there's no right or wrong as to whether you should or shouldn't have an anti-androgen tablet along with your injections. Now, too much hormones can be bad. Okay, certainly it controls your cancer, but it causes lots of side effects. Okay, so how do we minimize the amount of side effects that these hormones cause? Well, we do something called intermittent androgen blockade. That's intermittent hormone therapy to a lot of people. And what intermittent hormone therapy is that when someone needs hormone therapy, we put them on the injection for usually about 6 months. Some people put them on for 9 months until the PSA comes right down to a very, very low level. Then after that, we know that the cancer is really, really tiny, probably microscopic. We stop the hormone therapy. And when we stop the hormone therapy, the testosterone is going to come back. When the testosterone comes back, the cancer is going to start growing. Now, a lot of you may think, well, geez, that sounds terrible. You know, you've got it down really small. Why would you want it to start growing again? Well, the reason why you do is because when it starts growing and it gets to a certain size, you can give them the hormone therapy again and shrink it right back down again. And you can keep on doing that 6 months on and then off until the PSA rises to, say, about 10 or whatever the decided cut point is. And if you do that, you can actually, there have been 3 randomized studies now that show that the cancer remains very, very responsive to the hormones longer than if you had it continuously. Okay? So there's a very, very good reason for doing that. The second reason is because it's been well proven that if you stop the hormones for a while, you're going to get a better quality of life. Makes sense. You're not going to get the side effects, are you? So that's another important reason. Third reason is some of you will actually be paying for part of the drug at least, but it saves money. So that's another good reason for it. Okay, so most of us have started doing intermittent androgen blockade or intermittent hormone therapy now for all of those reasons. But there are some caveats. If you have a lot of cancer, it's been shown not to be that useful. Okay, so you need to talk to your urologist or whoever it is that's treating you as to whether it's appropriate or not. And not all patients are appropriate for it, but if you have a small volume of cancer or you can't find the cancer, it's just a PSA, it's very good. And I guess this slide's basically just explaining how we do the intermittent hormone therapy. Now, after hormone therapy will work for a while, but after a while it will stop working. And the reason for that is if you look at these cells, this is the original cancer that a man has had. Okay? The vast majority of the cancer is composed of what we call androgen-dependent cells. That is, they're very, very responsive to testosterone. And if you take the testosterone away, they'll die. but there are also some of what we call independent cells. These are little prostate cancer cells that actually don't need testosterone to survive. So when a cancer develops, spreads to the bone, and then you take the testosterone away, the cancer shrinks down. But what happens is that these dependent cells are the ones that are actually dying, and the independent cells, the cancer cells that don't need testosterone, are actually surviving. Okay? And with time, those independent cells are the ones that grow and become what we call castrate-resistant. And if you think about it, with intermittent hormone therapy, what's happening is that this is happening, and then we're letting it grow back to that size, letting the dependent cells grow back, and then we're giving the intermittent hormone therapy again, shrinking it back down to that. So we're basically just cycling between these two groups. But eventually, this will develop castrate-resistant prostate cancer. So what that means, what castrate-resistant prostate cancer means, that despite having zero testosterone, your cancer is growing. And then we've got to look at different treatment options there. The first thing we do is we add an anti-androgen, because sometimes we find that if you add Cosidex or something like that, the PSA starts dropping and the cancer shrinks a bit. Happens in about 30% of men. But that doesn't last too long, usually about 3 months to 7 months. When that stops working, then we've got to start looking at different options. Now, one of the questions I always get asked is, do you still need to continue taking your injections, the Zoladex, the Leukerin, etc., because your cancer's growing? Is there any point? And the answer is yes, and there have been a number of studies that have looked at it, and your cancer would actually grow faster if you stop taking the injections, because there is still some bit of responsiveness to testosterone. So if you let the testosterone come back by stopping the injection, your cancer would grow faster. So, how do men know that they've developed castrate-resistant prostate cancer? Well, usually the first thing that happens is that the PSAs have been at very low levels, and then they start rising. At that stage, we normally measure the testosterone level just to make sure that the injections are actually working and the testosterone is very low. In some men, in addition to the rising PSA, you may get cancer on scans. This is actually a PET scan that's increasing. Or you may actually have symptoms from your cancer, and your symptoms are getting worse, like increasing bone pain. Now, when this happens, what happens? Well, there's 3 potential problems. One is local problems, one is bone problems, and the last thing is what we call systemic problems. Local problems are basically the cancer in the prostate, if the prostate's still there, starts growing. And it can cause pain, difficulty urinating, and blood in the urine. And we as urologists need to sort that out for you. In the bone, if the cancer spreads to the bone and the cancer in the bone starts growing, then most commonly you develop pain. But occasionally men can present with what we call a pathological fracture. That is, they're not doing very much at all, and one of their bones breaks, maybe in the back, maybe in the hip, maybe something like that. So obviously you need to come to hospital and have that fixed. And the last thing, systemic, is where the cancer can replace the bone marrow in the bones, and you get tired from anemia because your bone can't produce enough red cells. But these are all very, can I stress, very, very late problems. And they don't really occur that frequently at all. So how do we treat it? Well, when we get to that stage, chemotherapy is the next point of call. Okay? Chemotherapy sounds terrible, but in reality, it actually does palliate patients very, very well. It gives very good relief of pain, and it's actually been shown to improve quality of life. Now, a lot of you may be thinking, oh, chemotherapy, I haven't heard that improves quality of life. Most people feel dreadful. Well, that's actually not true. There have been quite a number of studies where men with prostate cancer have been given chemotherapy, and because they're already feeling pretty bad, the chemotherapy actually improved their quality of life. And chemotherapy improves survival. So that's why we give it. And the first line of chemotherapy we give is something called docetaxel, and it's given every 3 weeks. And when we compare it to another drug which we used to give, the survival is significantly improved. It actually improves by about 24%. So it's made a big difference to men with prostate cancer. And all sorts of men benefit from the chemotherapy. What you see here is something we call the forest plot. And if it's on this side of the line, it means that there's a benefit. And you can see men over the age of 75 benefit just as much as men over the age of 65 and men less than 65. Whether you have pain or not, you can benefit from chemotherapy. And this is actually a measure of how active you are. Whether you're active or not, men still benefit from the chemotherapy. And quality of life actually improves very dramatically as well. You can see here with the chemotherapy, there is a very significant improvement in response compared to the other chemotherapy, which was less effective. And this is a scan of a tumor from the original study that looked at docetaxel, where you can see that it was certainly there and disappeared within a few weeks. But after you've had docetaxel, and most men will have usually about 6 cycles, some will go on to about 10 cycles, and remember it's given every 3 weeks. Somewhere along the line, the cancer will continue to grow. The chemotherapy does not cure the cancer, but it will certainly slow it down. What do we do then? Well, there's a new drug that's just come up, and there have been some fantastic clinical trials that have shown that this new drug actually works very, very effectively after docetaxel. So now we've got 2 very effective drugs, docetaxel and cabazitaxel, that work well in men with advanced prostate cancer. If you're not well enough to take this drug, then we can give mitoxantrone and prednisone. And this also improves pain relief and makes men feel better. If there's a lot of cancer in the bones, we can actually give what we call systemic radiotherapy, which is radioactive material which seeks cancer in bone. We give it through a drip, and it's called strontium and samarium. And what it does is it goes to cancer in the bones, and it sits there, and the radiation then kills the cancer in those bones, in those bone metastases. And this is a curve of the treatment with cabazitaxel compared to the old treatment, which used to be mitoxantrone. So these men have all had docetaxel, and the cancer has grown after docetaxel treatment, and there's still lots of men that are improving on cabazitaxel. Now you may have heard about a new drug called abiraterone. Hands up those that have heard of this drug. Yeah, it's got a lot of publicity, and I think it's well deserved. Abiraterone is a new form of hormone therapy. Okay, the ones that I've talked to you today, basically what they do is they block the hormone that goes to the testicles that produce testosterone. What abiraterone does is it actually gets into all of the cells that produce any androgen. So it goes to the adrenal cells, it goes to the testicular cells, it goes to the actual prostate cancer cells, because prostate cancer can actually produce its own testosterone. And what it does is it completely shuts down any ability of any of those cells to produce it. Okay? And they've done trials of abiraterone in men that have had lots and lots of hormone therapy, lots and lots of chemotherapy, and it still works. And so we're talking about, very, very aggressive and fast-growing cancer, but it still works. And so this is placebo, and this is abiraterone in these very highly treated men, and there's a significant improvement in survival. And we're talking about 100 to 150 days. So it's a small study, so we need to confirm it with bigger studies, but I think abiraterone in the next 3 to 4 years is going to make a huge impact on how we treat prostate cancer. I think it's going to be brought earlier and earlier and earlier. Instead of being given after chemotherapy, I think we're going to soon see that it's going to be given before chemotherapy. There's another drug, MDV-3100. Okay, this is an anti-androgen. So what it does It's a drug that blocks testosterone or any other androgen binding to a receptor on a cancer. Okay, but it's much more potent than the current study drugs that we're looking at, much more potent than Cosidex. And this is what we call a waterfall plot. That is, patients are given this drug, and then we measure the change in PSA after they've been given the drug. And look at this, a large number of patients had 100% drop in their PSA. That is, the PSA almost disappeared. And the vast majority had some degree of effect. And only a very small proportion of patients, the PSA actually increased while on the drug. So again, this is still in very early trials, but I think in the next 2 to 3 years, we're going to be seeing a lot more of this drug, and either this one or drugs like it that are much, much more potent than our current class of drugs like Androcur and Cosidex. And the last thing I want to talk about is Provenge. Who's heard of Provenge? Yeah. So this is basically vaccine therapy. You know, if we talked about vaccine therapy 15 years ago, we would have said, oh, it's just rubbish. You know, how can a vaccine possibly kill or cure such an aggressive cancer? Well, Provenge has proven us wrong. It's something called a dendritic cell vaccine. That is, there are immune cells in the body called dendritic cells, and these cells are harvested from the patients. They're stimulated so that they become very, very active. And they're also pulsed with something called prostatic acid phosphatase, and that's something that you can only find in prostate cancer. So these immune cells have been given little bits of prostate cancer. They've got really, really angry, and they've been taught how to fight this prostate cancer based on what they've been pulsed with. And then they get put back into the patient. Then they run around the patient looking for any sign of prostate cancer and attack it. And it's great. You know, docetaxel had a survival advantage in the biggest clinical trial we've done of 4 months, 3 to 4 months, right? Vaccine therapy had exactly the same survival advantage. So it is as effective as chemotherapy, but much, much, much less toxic. Okay? And so we're very excited about this. It's got approval in the United States. Unfortunately, at this stage, it's not looking like it's going to be in Australia in the near future, just because, as you can guess, it requires a lot of expertise. It requires a special lab that can do all of this work, and it's very, very expensive. It's unlikely that patients are going to be able to actually pay for it themselves. And so, you know, we really need the government on board. We need a lot of finance to get the whole lab, etc., set up. But the other important thing is that we've proven that dendritic cell or vaccine therapies work, and they work well with very little side effects. And I think this is only the start of a huge line of vaccine therapies that we're going to now see for treatment of advanced prostate cancer. And this is the Provenge's actual name is called Sipuleucel T, and you can see here the survival curves are much, much better than the placebo curves in men with castrate-resistant prostate cancer. So I'm going to move now to bone. Okay, in prostate cancer, bone bears probably the brunt. Have I got time, David? Yes. Yep. Yeah, probably bears the brunt of cancer when it becomes advanced, and the vast majority of it, well, number one, there's a couple of things we can do. When you get cancer in the bone, we can give radiation to it, and it does improve the pain. Unfortunately, cancer in the bone can cause what I've talked about earlier, pathological fracture. And one of the major problems that cancer in the bone can cause is that when it's in the spine, if it grows, it can cause a fracture, or it can grow into the spine, causing paralysis. Now, that's very rare. And it's also why we always ask our men if they have any new bone pain in their back, because it needs to be treated fairly urgently. And radiotherapy has a very important role in men who have cancer in the bones. Okay? If there's only 1 or 2 spots that are painful, radiotherapy is very, very successful in getting rid of that pain. And you really only need one zap of radiotherapy to a painful metastasis, and it works for a long, long time. And even if you don't have pain in certain bones, like if you've got a hip which takes a lot of weight when you're walking around and it appears like it's got a lot of cancer in it, we may actually choose to give it radiotherapy even before it's painful. Okay. Now there's a few other techniques we have in protecting the bone. Okay, now if this is your bone, there are two different cell classes within the bone. There's the osteoblast, which makes bone, and there's the osteoclast, which resorbs bone. Okay, and in everyone, me, you, everyone around, there's a continuous cycle of bone being put down and bone being resorbed. Now, unfortunately, when you have prostate cancer cells in the bone, what they do is they stimulate the osteoblasts to put down more bone, and that keeps the whole cycle actually going faster and faster. Now, there's a drug called Zometa, which is a class of drug called bisphosphonate. And what Zometa does is it actually paralyzes the osteoclast and hence stops that cycle happening. Okay? And the reason why you need to stop that cycle happening is because when you have that cycle, it actually causes disorganized bone architecture and weakened bones. And you can see here, this is a study of men that had prostate cancer, that were castrate-resistant. And in the blue line, they had Zometa, which is zoledronic acid. And in this one, they had the placebo. And there was a much, much longer time to men developing a fracture if they took Zometa than if they didn't. So this was a pivotal trial showing that Zometa actually improved the bone health of men on prostate cancer. It does have side effects. It makes you feel like you've got a flu-like illness, and it can lower your calcium levels, so that needs to be monitored very carefully, as does your kidney function. And in some men who have poor dental hygiene, it can actually cause the jaw to die in certain parts, called osteonecrosis. But that's a very, very rare complication. But more recently, there's been a new drug on the market called denosumab. And denosumab is actually an antibody, and it's given by an injection just under the skin into the fat. And denosumab actually stops that cycle happening and weakening of the bones as well. But the good thing about denosumab was that it was compared to Zometa and found to be much better than Zometa in decreasing fractures in men who have prostate cancer. And the reason why these fractures occur is, number one, the bone gets weakened because the cancer's in there, but also, remember, all of these men are taking hormone therapy, which also weakens the bone through osteoporosis. And so that is the end, and I'm very happy to take questions because I think we should have plenty of time.
Yes, thank you.
You didn't mention ketoconazole and treatment of castrate-resistant prostate cancer.
Okay. You're right. I didn't, because I don't know of anyone in Australia that's actually been treated with ketoconazole. When I was in the US, that was a standard, what we call second or third line treatment. Ketoconazole is a drug that stops adrenal gland from producing hormones. Unfortunately, the adrenal gland produces a whole bunch of different hormones. And instead of just stopping the androgens, which is what you wanted to stop, it actually stops the adrenal gland producing a whole heap of very, very important hormones called cortisol and mineralocorticoid, which is essential for life. And so it's very toxic. And the men I saw taking ketoconazole in the US looked dreadful. So in Australia, we tend not to give it. But now that we've got abiraterone, I don't think even in the US they're going to use ketoconazole.
So just a question, you mentioned with ADT the side effects. Can you give us some idea of the significance of those side effects? Are they large, small, or how different to not having ADT?
They're big, but not every man experiences side effects, and you know, there's quite a few on the list, and they have different percentages. For example, if you look at osteoporosis, we think that's one of the bigger ones. With regards to osteoporosis, men on ADT will lose about 6% of their bone mass a year. Okay? Now, not every man will, but on average, about 6%. And 6% of your bone mass is actually quite important. Hot flushes, probably about 70% of men will have difficulty with hot flushes, but vast majority of them will tolerate them. Things like increased risk of heart attacks, that risk, there haven't been very high quality studies done, but we think that increased risk is probably about 15%, so it's not huge, okay? But it's there. Are there any other specific side effects that you wanted numbers for? Okay.
Thanks for your talk, Manish. I just wondered, those new drugs you mentioned, and you said they were going to be here soon, are you allowing for them to be on the PBS?
No. Okay. To get on the PBS, as I'm sure you all know, it takes a long, long, long time. A drug company with a new drug will usually have to present it about 3 times before the PBS, before it's accepted, and that's assuming that they've got very, very strong data. Okay. At the moment, the most of the drugs that I talked about are still going through clinical trials, and I think if any of you are at that stage of disease, the good news is you're likely to have access to it on a clinical trial. Gavin Marks runs a very good clinical trials program, and he is usually running one of those drugs on a clinical trial.
Yeah, that's a very important point, Manish. Thanks for mentioning that. Next one. Geez, Graham, you've got a few over that side.
Do you want to go first? When you talk about the intermittent treatment, why wouldn't everybody do that as a start? The way you presented it, it seemed like you wouldn't be on there permanently.
The reason why everybody hasn't been started on intermittent, including a lot of my patients, is because that data's just come out. That's the first one. I mean, people have been doing it for a while, but the data that proves that it's safe, and as safe as having continuous from a cancer point of view, has only come out in the last year. The other point I'd like to make is that if you have high volume cancer, there's lots of cancer in the bones, intermittent's not the right treatment.
With ADT,
Wait for the...
sorry, with ADT, can your PSA, like say if you've had those injections, can your PSA go down to negative?
It can't go negative, but it can go to what we call undetectable, as in it's so low that the assay can't detect it at all.
All right, thank you. Sorry.
I've got one up the back. David, you go first. Oh, okay. I've got one up here. That was a false negative.
I was just wondering, you were talking a lot about the androgen, the hormone therapy of removing hormone therapy, but in a younger, healthier man, there's, as there have been with women for years, talking about adding hormone to protect and prevent against osteoporosis. They're now talking a lot about adding testosterone, you know, to men who have low testosterone levels. Does that, can that potentially give you a higher risk of getting prostate cancer or developing it if you're taking testosterone therapy as a younger, healthy male, but just happens to have a lower testosterone rate?
I assume we're talking about men who have never been diagnosed with prostate cancer.
Correct, yes.
Yeah. No, there's no study that shows that if you have low testosterone and you're having supplemental testosterone to make it normal, that it increases your risk.
Well, okay. If I have time, I had a second question. With the radiotherapy you were talking about earlier, you were talking about the external versus the brachytherapy, and then the side effects for incontinence and ED. Is there a difference in the percentage of those side effects, whether you get it as the brachytherapy you were talking about, or you're using even if you're using the shaped beams?
Yep. There hasn't been a head-to-head comparison like a randomized trial between brachytherapy and IMRT. There should be, but there hasn't been. So what we do is we look at the side effects from different series. Say this institution does brachytherapy and that institution does IMRT, and we look at their side effects and try and work out what's happening there. What we think is happening is that because the HDR brachytherapy gives the high dose directly within it, and less of the dose goes to the bladder and to the rectum, the rectal and the bladder side effects appear to be less with HDR brachytherapy as opposed to IMRT. And they're the main side effects. It's like urgency, frequency, needing to, burning, stinging when you're urinating. With the rectum, it's needing to go to the toilet all the time, diarrhea, occasional rectal bleeding.
You've got one up the front there.
My question's a little outside your presentation tonight, but my brother had his operation last week, laparoscopic. Now, can you explain to me, where they have 4 keyholes, how they remove that prostate? The prostate's about that big. How is it removed from the body? I know with gallbladder they deflate it and it comes out through the navel, but how do they remove it on laparoscopic? Could you answer that for me, please?
Same way, it still comes out through the navel. What happens with the prostate is once you disconnect it from its blood supply, it shrinks a bit.
I saw one that's been still a fair size.
Yeah, so I mean, have a close look at your brother's wounds. You'll notice you'll notice the belly button one is a little bit bigger.
Right, so he's on the Gold Coast.
Oh, okay. So we put it in a bag and squeeze it through. And we do the same thing robotically. Now that I'm doing the robotic thing, it comes out through the belly button through a slightly bigger cut.
Thank you.
Over here.
Oh, sorry.
Thank you for your presentation. Just expanding on the where you mentioned about the undetectable PSA levels. Can you expand on that a bit more? What do you call the undetectable levels? Is it 0.01 or 0.00 something? I'm just not sure how many zeros there should be.
Okay. The important thing is not how many zeros there are. The important thing is at what level do we say, well, this doesn't look good, it looks like a recurrence. Okay, because a lab can just get better and better in assays and get more and more zeros, but that doesn't mean it's any better for you, right? It's 0.2, okay? If you get to 0.2 or above, in most cases you've got a recurrence. This is after prostatectomy, okay? If you have radiation, it's different. There's a different criteria for radiation. With radiation, what we like to see is the PSA comes down and then goes to what we call a nadir, okay? If it then rises by 2, then you've got a recurrence at that point. So there are different definitions after radiation, after prostatectomy.
Over your side, Grant.
Yeah, how low should your prostate, your PSA number come to be taken off hormone treatment?
I probably need more information there. So if someone has cancer in the bones,
yep,
and you've started hormone therapy,
yes,
and your PSA's come down,
yes,
and you're asking how low should it get?
yes.
Okay. Ideally, the lower the better. Okay. There have been lots of studies that show that the lower it gets, the longer the hormone therapy is actually going to work for you. Okay. But there's no absolute level that it needs to get below 10, it needs to get below 4, it needs to get below 1. There's no absolute level. It's just that the lower it is, the better it is for you. But even if it gets to 4 and doesn't go any further, it doesn't mean you're not going to have a good response for it. It just means if it gets to 0.5, it's going to be a really good response.
Thank you.
Okay. And then there's one up the back.
Okay. You had said that rapidly rising PSA means that the cancer is more distant.
Correct.
Right?
Yep.
So
just to clarify for everyone else, this is after prostatectomy and the PSA is rising.
Yeah. So if you have started on HRT, right, or say when you have
androgen deprivation therapy, not HRT.
Now, sorry. Okay. Now, where does mammogram come into? Like, can you have if you want to find out where the cancer is, would you do it at that point, or that is done earlier, or?
No, there's a nomogram, for the earlier point. There might actually even be a nomogram for that one, because I heard someone was developing it. I haven't seen it published yet, but there might be one for working out where it is, or rather predicting where it is. And
if you can predict where it is, what would you do?
Well, if the prediction suggests that you've got a high likelihood that it's in the pelvis, then you'd give radiation.
Okay.
Okay. But if the prediction is that it's more likely to be somewhere else, lymph nodes or bone, then you give hormone therapy.
Okay, thank you.
Dr. Patel, I was wanting to know the answer. Is there an exact correlation between your PSA and the amount of cancer that's in your body? For instance, if your PSA went down spontaneously, let's say, does that mean the cancer is in some form of remission?
There's not an exact correlation, but it's pretty close. Okay, the time when the correlation tends to deviate is when you get to the later end of disease, like when it's castrate-resistant. That is, it's not responding to the hormones very well. That's when the level of PSA may not strongly correlate with the amount of disease you have. But early on, before you've had hormones, or while you're undergoing hormones and the hormones are still working, there's a very, very good correlation.
One last question. All overdone. Oh, one in the middle.
There's one here. Yeah.
Oh, one here, sorry.
Could I just ask with the PSA, if it's 2 years prostatectomy, 2 years after, and you're almost to the 2, then it would be 0.2, it would be radiotherapy if you're at a 0.18?
So, 2 years after prostatectomy, PSA has been slowly rising and now it's about 0.2.
Mm-hmm.
It's certainly suggestive. I mean, I'd need to know a lot more other criteria. For example, what the Gleason score is, what the original PSA was, whether there's positive or negative margins at the prostatectomy. But based just on that PSA, it's more suggested that it's local and radiotherapy would probably work pretty well.
It was out of the capsule to start with.
And were the margins positive?
Yes.
Okay, so that increases the likelihood that it's local.
Mm-hmm.
So if you have positive margins and a slowly rising PSA, which it has been, then it's likely to be local.
Thank you.
Graham, okay.
I'd like to ask another question, please, about salvage prostatectomy after radiotherapy. Why wouldn't you have not done the prostatectomy in the first place, and then, because you said the complications of salvage prostatectomy are much greater than doing prostatectomy first up, followed by radiotherapy. So why would you do it radiotherapy first, followed by salvage?
Whenever someone's diagnosed with prostate cancer, they're given all the options of treatment, and some people actually choose radiotherapy as their first option.
Is that a wise choice?
Well, you've answered your own question. but it's quite interesting because Manish mentioned the salvage procedure, and normally, or years ago, it was more prevalent to say that once you undertook the option of radiotherapy, then an operation wasn't possible. But these days it is, isn't it?
I think people should, when they make their initial decision, should really think of it as not being possible, and then they'll be very, very lucky if the PSA recurs after radiation and they're suitable. Because remember, only a small percentage of men after radiation are suitable for salvage prostatectomy. And having said that, I think there's probably only about 3 surgeons in Sydney that actually do it.
So you've got to make your choice wisely.
Yeah. Don't depend on the fact that you might be able to get your prostate out afterwards.
Yeah. Now, last time I said, are there any others? Are we all over? Done? Sound like an auctioneer, don't I? Well, I was one once.
Am I sold?
Okay, so Manish, congratulations. It was really another very informative and stimulating presentation. It gives a lot of the people in this room hope, and with more knowledge, they can cope with their particular part of the journey. So we really appreciate your time tonight, as we always do. And just a reminder that Pam writes this up, and Manish, as a visiting medical professional, vets the words, and it'll be published in the newsletter. and this DVD will be available. So it's all very good, and we really appreciate your time. So help me thank Manish in the normal way.